Hi, everyone. Well, good afternoon and welcome to today's special edition Care Connection webinar. My name is Laurel Gumpert and I'm the Educational Program Coordinator here at the Alzheimer's Foundation of America. I am very happy to be here with you all today. Today's special edition's Care Connection webinar is asking a very important question that I know is on many people's minds. So today we're going to be uncovering how many pills are too many. This has been a widely anticipated care connection, so I'm looking forward to learning with you all today. So before we get started, I'd like to let you know that all lines are currently muted, but we're going to have time for a Q&A at the end, as well as a moment in the middle to answer a question. So on the right-hand side of your screen, you'll see a little question box, and you can type in any questions, anything you may want. You can just say hello in that question box on the right-hand side of your screen. And I really encourage you to utilize this opportunity to ask any questions that you may have. If there are any questions that we don't get to, I encourage you to call AFA's national toll-free helpline that's staffed with all licensed social workers, 12 hours a day, 7 days a week from 9 a.m. to 9 p.m. Eastern. And I will put that number in our chat box as well. So with that, I'd like to introduce our returning special guest today, Dr. Gerda Maisel. She spoke with us last month about healthcare advocates and geriatric care managers, and today she's helping us out and we're looking at medication. For those of you who may have missed her last time, she's a physical medicine and rehabilitation physician and a former hospital system executive. Dr. Gerda also founded My MD Advisor, which specializes in helping people with complex medical issues such as dementia get better medical care. With that, she is a board-certified patient advocate that serves families and individuals with these complex medical problems. And for more information on My MD Advisor, I'll have her website in the thank you email that we send out afterwards, so you'll be able to check that out as well. So we're very grateful to have you again speaking with us. So without further ado, the floor is yours.
Well, thank you, Laurel, and thanks everybody for taking the time to be here today. I do really want to hear from you, so please do put your questions in the chat. There will be a section in the middle of this talk where I want you to write down some ideas and then put those ideas in the chat. So there's a little bit of an interactive session in the middle, but other than that, you just get me talking to you, and then we'll do questions at the end. Okay, so, and I will answer this question about how many pills is too many towards, it's in the middle of the talk. So whenever I listen to talk, I always like to have some sense of who the human being is that's talking to me. So this is just a little bit about me and my journey. So my journey actually began back in the late 50s when my mother was pregnant with my older brother. She caught German measles. He was born with congenital rubella, which meant that he had significant cognitive impairments, speech, hearing, visual impairments, and his care was the center of my family's focus for a lot of years when I was growing up. And during that time, I saw my mother and my brother treated with a lot of indignities. They weren't treated with respect. Her input, my mom was a very smart lady, but her input was not always valued. So I became a physician in part because I wanted to change things. And I picked this field called physical medicine and rehabilitation because it's about function. It's about helping a person, do as best as they can within the context of their life. Well, I got pulled into C-suite leadership, did that for 10 to 12 years. During COVID, reconsidered my priorities. And my mom, who is now 91, was here in New York on her own and was feeling very isolated. And I decided to have a COVID baby, and I started My MD Advisor to help people through the healthcare system. So that's just a little bit about me. That's my little logo. That's what I'll look like in 30 years. I do look a bit like my mom. Okay, today. So what we're going to talk about today is we're going to tell a story, basically, a case example about what is known as polypharmacy. Poly means a bunch, pharmacy drugs. So polypharmacy is really the topic. But we're going to talk broadly because if I just gave you a list of drugs, you'd be really, really bored. So we're going to go into the case example. That's where you're going to have some input. We're going to do a polypharmacy definition. We're going to talk about some common issues. We're going to go over some non-drug alternatives to medications and finish up with just a little bit on how to get help. Okay, so let's see. So we're going to start with a case study. This is Alice. Alice is 85 years old. And she's generally pretty healthy. She's got high blood pressure, diabetes, some seasonal allergies. She doesn't take a lot of medicines. She takes some Lasix, which is a common water pill, and she takes potassium because you usually need to take potassium with the Lasix. She takes metformin, also known as glucophage, for her diabetes that are well controlled, and occasionally for her allergies, she takes some Benadryl. She lives on her own with her dog, and she used to exercise, but lately she hasn't been doing as much as she did in the past. She used to like to swim, but she hasn't been doing that recently. Oops, I went the wrong way. Sorry, sometimes this does this. Okay, here we go. But Alice developed some trouble sleeping. So Alice tried to treat the sleeping problem on her own. First, she took some Tylenol PM, which by the way has Benadryl in it, and she took some melatonin, and it didn't work enough. So she went to see her doctor and said, look, I'm not sleeping well, and it's making me tired all day long. So the doctor gave her some Sonata. Oh boy. Okay, come on. There we go. So she was doing okay. She was feeling a little bit better. So Alice decided that she wanted to cook something, a stew, in her favorite Le Creuset pot. Now, I don't know if any of you have one of these kind of pots. They're cast iron enamel pots. They're, it's a cast iron pot, which is really heavy, and it's covered with enamel. They're wonderful pots. They make wonderful stews, distribute the heat beautifully. Well, Alice lifted a little bit wrong in pulling that pot out from under the counter where she was storing it. She hurt her back, and her back was in spasms. So Alice went to her doctor, and the doctor said, you'll be okay, but I want you to rest for a few days. I want you to go to physical therapy. And here's Flexeril, which is a muscle relaxant that'll help the back spasm. And here's some Percocet, and that'll help you get through the pain. Well, Alice fell. Alice fell. Now this is going to be your part, and she broke her hip. And we're going to go through what happened after Alice fell and broke her hip. I want you to think about and take a minute. You can write down, you can put in the chat, why did Alice fall? If you were paying attention, you will have caught, I gave you a number of hints of possible reasons why Alice might have fallen. So I want you to write down at least 3 possible causes, put them in the chat. I'm going to have one slide, and then I'm going to have Laurel read some of the answers that you guys came up with. So I'll give you a second. So why was Alice at risk for falling? Why do we think she fell and broke her hip? Okay, so you write that down. I'm going to tell you what happened to Alice in the hospital. Well, Alice came into the hospital and they gave her more narcotics for pain. They put a catheter in her bladder because now her hip is fractured and she can't move. And so in order for her to empty her bladder, the catheter makes it more comfortable. And they took Alice off to hip surgery. Well, she did have her hip surgery, and the surgery was successful. But now Alice developed a urinary tract infection, a UTI. Now, why did Alice develop a UTI? Maybe it was the catheter in her bladder that put her at risk. And women are at much higher risk of urinary tract infections. And older women are especially at risk because there's often vaginal atrophy, which makes it just a little bit easier for those bacteria to get into the bladder and cause urinary tract infections. Well, with that urinary tract infection, Alice got confused. Now, she might have also been confused because she just had surgery and some of the meds were hanging around. Remember, she's 85. She also was given narcotics, which probably didn't help. And now she has this urinary infection. And by the way, in medicine, we call this the slippery slope. See this over and over. One thing happens and it leads the next to the next. So when Alice got confused, she got a bit agitated and anxious and upset, and she started pulling at her oxygen, at all her lines. And the nice doctors thought, well, she's very anxious. You know, she's in the hospital and she's not feeling great. So they gave her anti-anxiety medicines. So now we have anti-anxiety medicines, recent surgery, and narcotics, and Alice becomes quite sedated. And when she's sedated, she doesn't, I'm going to try to, I don't know if you can see that thing. She doesn't take the same deep breaths that are necessary. So what happens then? Alice now, on top of her urinary tract infection, on top of her hip fracture, she now has a pneumonia. Well, eventually Alice does recover, but she goes to rehab. It takes her several months to, sorry, I'm trying to get rid of this little thing here that I can see. I don't know if you can, I got rid of it. All right, there we go. So Alice does have to recover, but instead of it just being a simple thing, after all these different infections and all these medicines, she has a very long recovery. Okay, so now let's go to why we think Alice fell.
Yes, and we have people, I am so surprised, so many different answers. So thank you all so much for your ideas. This is great. I'm just going to start giving you some of people's ideas.
Great.
We have someone who said she was taking different medications that are sedatives. Someone also said that she may be unsteady from medication and dehydrated from taking water pills.
Yep.
Someone
Good.
also said too much medication with a muscle relaxer and pain medication.
Yep.
We have double Benadryl, the sleeping medication and the pain medication. Others, again, too many medication, the Tylenol PM, Benadryl, sleeping pill. Tired and weak and lacking fluids from all of the medicine. And maybe she had balance issues before and the pot may have just been too heavy for her to lift. So that's the general summary of the ideas we've had so far. So great job, everyone. This was a lot.
That's great. You guys did a really good job of coming up with a lot of good reasons. I'll show you the ones that I came up with. So let's jump to the medicines, because obviously this is a talk on medicines and you guys picked up on all the right things. The Lasix, the water pill, could have left her dehydrated. The other thing that can happen with a water pill like Lasix is it makes you need to pee. Now, when you need to pee, sometimes you get urgency and you go run into the bathroom and you can trip and fall. The sleeping pill could have left her a little dizzy and feeling crummy. Same thing with the Percocet for her back pain. The Flexeril, the muscle relaxer, has similar side effects to the sleeping pill and the Percocet, which is it can make you feel a little loopy, a little dizzy, kind of weak. And as somebody picked up, I did mention it, and good job, Tylenol PM has Benadryl in it, and if you take Benadryl on top of that, you could end up with too much Benadryl. And antihistamines are, we call them anticholinergic medicines. They can make you feel dizzy. It's a common side effect. There are other non-drug reasons too. Remember I mentioned Alice had sort of stopped her exercise, and being deconditioned, not having your muscles in great shape, doesn't mean you're going to fall from that. But if your muscles are not as strong and you go a little off balance, your muscles can't generate that force, that quick power to catch you, and it can increase your chances of falling. I threw in, if you caught it, that Alice is a diabetic. Diabetics over time, not everybody, it doesn't happen to everybody, but they can get neuropathies. And a common diabetic neuropathy is, we call it stocking glove. So it's like stockings and gloves when in its distribution. And what happens is people get numbness in their legs, they get tingling in their fingers. And one of the things is that they don't have that same position sense. They don't always know quite as well where their feet are. And people with diabetic neuropathies may shuffle. You see that also, of course, in Alzheimer's, but they may shuffle, keeping their feet more on the floor because they don't know where their feet are in space. It's very common with a diabetic neuropathy. Pain itself, if she was, she just hurt her back, she might have gotten slightly off balance for whatever reason, and then the pain made it impossible for her to catch herself. I did also mention Alice's cute dog. I happen to like this dog. It's not my dog, but it's a cute dog. Alice has a dog. Many people trip over their animals. Maybe the animal was underfoot when they stood up. Maybe they were trying to walk the dog and the dog pulled. Unfortunately, our loved ones, our pets, can be a cause of falls. And maybe there was some clutter. Maybe there were some dog toys sitting around, or maybe Alice had cords, all common reasons. And so this is obviously a hypothetical case, but once you get past the age of 75, 70% of accidental death after the age of 65 is associated with falling. So aside from this talk on medications, and this talk, while of course, I'm talking to you about Alzheimer's, and I'll have a few slides on Alzheimer's specific content coming up. I also want people to have this information about how incredibly important it is to make sure that you do things that reduce your risk of falling. Okay. This is just a sort of goes over this again from a different point of view. I've covered most of these things, but physical abilities, certain neurologic conditions like Parkinson's or strokes can increase the risk of falls. We didn't give Alice any impaired vision, but many times people, if you have a little bit of a neuropathy, you're using your eyes to compensate, which is why it also becomes important if you are unsteady on your feet and you're getting up in the nighttime to go to the bathroom, you may need to turn on the lights to reduce your chances of falling because your eyes do help you compensate. We touched on poor environment. And by the way, the term for getting dizzy when you stand up when you're dry is called postural hypotension. It's literally as simply as postural, meaning your posture, laying down versus standing up, and hypo is low tension. So when you get dizzy, when your blood pressure drops when you stand up because you took too much Lasix or you're dehydrated, that's postural hypotension. And we did touch on the bathroom urgency. Okay, let's go on. I always try clicking it this way. Okay, so this is something that we teach to residents to try to help them remember. We call it the 3 Bs. For medications that lead to falls. So brain, so sleeping pills, muscle relaxants, narcotics, benzodiazepines, which are the Valium type medicines, and anticholinergics are all drug categories that can affect the brain. And anticholinergics, we'll talk a little bit more about this again, but are given sometimes for secretions. When somebody has asthma or bad cold, sometimes they give an anticholinergic for that, and anticholinergics can be given to relax the bladder. All of those things can lead to the side effect of dizziness, confusion, etc. The second B is blood pressure. Believe it or not, high blood pressure meds have been shown to lead to falls when given in significant amounts. There was sort of the classic article was published in JAMA, the Journal of the American Medical Association, in 2014. And it showed a 30 to 40% increased risk of falling, and falling being defined as a fall with serious injury, when people were on moderate to high doses of high blood pressure medicines or hypertension meds. 30 to 40% increased chance of serious fall. Bladder meds I touched on. For most people, and you see these, overactive bladder commercials, meaning that your bladder's contracting a little too much and you want to relax the bladder. Well, those nice anticholinergic medicines relax the bladder. There's a variety out there. Ditropan's a common one, but you'll see many of them advertised. One of the side effects can be falls, so be aware. And then blood sugar, the third B, brain, blood pressure, blood sugar. When somebody is an insulin-dependent diabetic, sometimes they overshoot and their blood sugar goes low. And low blood sugar can, of course, lead to falls. And sometimes some of the other medicines as well can lead to falls. All right, so let's go on. The question that I asked early on is how many is too many? For the purposes of this conversation, I've included specifically prescription medications, but keep in mind that even supplements, which are not regulated by the Food and Drug Administration, can cause problems. So that's where we get into polypharmacy, and we talk about in medicine something called an adverse drug effect. An adverse drug effect falls into one of two categories. There's side effects like we've been talking about, but there's also drug interactions, and that drug interaction can then lead to side effects. So either one is considered, whether it's a side effect or drug interaction, can be a problem. And the drug interaction can be something where a particular side effect gets worse. It could cause a medicine to be less or more effective. But let me give you the percentages. Once you get to 5 or more, you have a 58% chance of having an adverse drug event on your medicines. When you get to 7 or more, it's an 82% chance that there is an adverse drug event that's likely to happen. And keep in mind, we're not talking frequency, so it doesn't matter if you're taking a pill 3 times a day, that still counts as one. And it even doesn't matter if it's a pill. If you've got one that's a pill and one that's an inhaler, doesn't matter how often each are dosed, each counts as one drug for these purposes. So we're not talking about the frequency, we're talking about the number of medications you take. So 5 with a 58% chance of an adverse drug effect is really considered too many. And we'll go into sort of some ways to look at reducing those. Common adverse drug events or side effects, interactions, things that you're going to experience are tiredness, confusion, slurring, delirium, which is people feel sort of out of body. They may sound very odd, very confused. They may see things. GI, meaning stomach pain, diarrhea, nausea, very common drug side effects. Sometimes pain, people will get muscle pain from some meds. Palpitations, the heart racing, rashes, bruising, bleeding, falls, etc. The chances of all these things happen the more medicines you take. And in today's world where Dr. A does not talk to Dr. B, a lot of times what happens is, well-meaning Dr. A, you come in, like in the story with Alice, she came in trouble sleeping, right? So she got a medicine. Then she went to see an orthopedist for her back pain, added on 2 more medicines. When you take medicines prescribed here, and then some baseline medicines, it can turn into a disaster. And the medical system is not set up well for a holistic look to be taken at what people at the medicines. And as much as today's electronic medical record does encourage that to happen, and there have been a lot of efforts, it still ends up being you as the family member or for yourself really looking into, do I want to maximize my treatment of every condition, or do I want to ask some questions and be a little more careful with what I'm taking? And we'll come back to that. But one thing I wanted to also touch on is why this matters to seniors. And seniors for this case, and it's getting awfully close, is really considered 65 or older. And what happens is that the drug dynamics in our bodies change. Our bodies change. So starting here with absorption, when you take, and we'll just say it's a pill, when you take a pill, it's got to go into your stomach, and sometimes the drug is absorbed in your stomach. Sometimes it travels out of your stomach and is absorbed into your duodenum or your small intestine. Well, the pH of your stomach can change a little bit. You can become more or less acidic, which can change how the drug is absorbed. The rate that you empty your stomach almost always slows down. And if you're a diabetic, there's something called gastroparesis or gastrostomach paresis, partial paralysis, where the stomach doesn't empty as fast. And that can cause drug levels in your body to change. Once a drug comes into your body, it gets distributed. And when it's distributed, some drugs hang out in our fat. And when they hang out in our fat, then they slowly kind of leach back into our blood system. Well, we tend to be a little heavier, have a little bit more fat, a little bit less muscle, even if our weight stays the same. Even if it doesn't, you tend to have more fat to lean muscle mass as you age. So you have the lipophilic drugs, the ones that like fat, hanging out longer, and the ones that aren't leaving faster. That can change. And then our protein stores, some drugs bind to our protein that circulates in our bloodstream. Protein stores are often a bit lower as we age. And then drugs, once they're metabolized, drugs are metabolized in the liver. Some are metabolized and cleared in the kidneys. Different drugs are cleared in different parts of the body. Liver function can change, kidney function can change. And in both cases, it affects the drug levels. We could end up with more of the drug hanging around. We could end up with less of the drug. The most typical thing is the drug is metabolized more slowly, and the metabolites themselves hang around longer. And so with all this stuff happening as we age, it's no wonder that people who are older almost always need a lower dose of the medication than they needed when they were younger. And unless it's deliberately chosen and geriatric dosing chosen, you can see people getting doses that are simply too high for them. And when those doses are too high, just like Alice at 85 probably needed tiny doses of things, and her doses that were given and that she was taking may well have been too high. It's a really common cause of adverse drug events. So I have a list, and you guys are welcome to the slide set. I don't want people to sit here and memorize these lists, because I have this list and it's followed by a list of specific drugs to be careful with in Alzheimer's. But I just want you to absorb the categories, and the lists, the names of the drugs are here just because it can be deeply confusing. So I just want you to maybe recognize a drug on this list. Don't try to memorize this. And again, if you want the slides, you're welcome to them. So narcotics, and not everybody realizes, but I'll just go through some of the drugs that are narcotics. Codeine, oxycodone, which is in Percocet and Roxicet. Hydrocodone, which is in Vicodin, Lortab, and Lorcet. Dilaudid, which is hydromorphone, and fentanyl. And we've heard a lot about fentanyl on the news, which is in Veragesic. Narcotics often hang out longer when you're older. You may need one for pain, but the effective dose may be lower. Sleeping pills, which are commonly prescribed to people who are older, are often, especially in combination with other drugs, a problem. And here's just some of the common sleeping pills that can hang around. Ambien, Sonata, Lunesta. And I mentioned already Tylenol PM, which has Benadryl, diphenhydramine in it. It's not that Tylenol PM necessarily hangs around longer, but Benadryl is highly anticholinergic, which is the thing that can cause confusion. Here's another category to be minimized as you pass the age of 65, which are benzos like Valium or Ativan, and muscle relaxers like Soma, Flexeril, etc. And here's a list that I want to, and when I say to question, I really mean it. You know, we don't need, I'm a doctor, but I don't expect that my patients do exactly what I say. I believe strongly in informed decision-making, informed choice. And whenever somebody wants to give you a medicine, it's worth asking not only what is this medicine supposed to do, but what are the side effects? What are the drug interactions? And also, what happens if I don't take this medicine? We doctors are trained, oh, problem, write a prescription. We think that every patient who comes in wants us to give them a prescription. But I urge you to question whether the medicine is needed or whether the dosage is needed. I've touched on and keep talking about anticholinergics, but I'll just review. These are the incontinence meds for overactive bladder, antihistamines, the ones that are a little bit better now that don't make you sleepy. Usually those antihistamines aren't as anticholinergic, but you can still have a problem from them. And sometimes people get Parkinson's type drugs that can also be anticholinergic and cause confusion and other problems. Steroids can worsen dementia symptoms. I mean, listen, if they're necessary, but be aware. And then another category, and these are used typically for high blood pressure, are beta blockers. Atenolol, propranolol, things that end in ol, can make Alzheimer's dementia symptoms worse. So we've talked about polypharmacy here, about, you can see that your chances once you get above 7, I think the stat, I wrote it down for you, 82% chance of having a problem when you're at 7 or more medications. So let's talk about reducing polypharmacy. Doesn't mean you have to, but rather I want you to think about what makes sense for you and your loved ones. So as I mentioned before, you should ask, what happens if I don't take this medicine? Ask about the interactions. Ask if the treatment must be done now. Whatever the symptom might be, does it need to be treated now? Or can I try something else? Or if it does need to be treated now, okay, tell me and we'll deal with it. Or maybe I can try something else, some other non-drug thing, and come back and see if I still need that drug. And then I also included here what I call maximal management. I have seen doctors and patients and families try to make sure that every symptom a person has is maximally managed. And you end up in a situation where one drug, then another drug, then another drug, and you're chasing maximum symptom management of a whole bunch of different illnesses. And sometimes you have to choose. Sometimes you have to talk to your doctor and say, okay, well, we know that these two medicines have overlapping side effects. So, let's go through the pros and the cons of which one I really, which do I want, what symptoms or illness am I willing to not maximally manage, and which one do I think is really important to maximally manage. So just recognize all your choices have trade-offs, but ultimately the choice is yours. And I just believe in informed balance. Get the information and then decide what you think is right. I do believe when you can, seek non-drug alternatives, but of course, talk to your doctor before you stop anything. And your doctor, will be a great sounding board and likely quite happy, a good primary care will be happy to partner with you in reducing polypharmacy. So let's also just put a slide in here about reducing drug impact in Alzheimer's. So let's say there's a condition or conditions that really do need to be treated. Well, go low and go slow. So for example, I had a client, the doctor wanted to start her on a pill. The starting dose he wanted to choose was 10 milligrams. I knew that it came in a 5 milligram pill, and that with a pill splitter, we could get it down to 2.5 milligrams. And this was a 90-year-old woman. I asked him on the client's behalf, what do you think of starting at 2.5 milligrams and letting it go for a couple of weeks and see, this was actually a blood pressure medicine, and see if there's a good result. And the doctor was agreeable, and we ended up adjusting the dose every couple of weeks. And instead of this drug that he wanted to start at 10 and rapidly max up to 50, we started at 2.5 and her effective dose was 5. So you never know. People are different in how they metabolize and how they respond to drugs. But let's say someone has started, someone you love has started on a drug, your loved one has Alzheimer's and they need the med, you started low, just watch carefully for changes. Common changes in response to meds will be unsteadiness with walking, confusion, or perhaps even agitation. Not uncommon to see somebody, get more agitated as a result of a medication. And that's where you've got to weigh the balance. And we'll get into, but when possible, seek non-drug alternatives. So now we're going to talk a little bit about non-drug alternatives. And there's a little an acronym here called REDS, which stands for rest, exercise, diet, sun, and sleep. And they're kind of, I know you know this, but it never hurts. It's kind of things that help you have a healthy life, and this is real. So exercise, what are the current guidelines for exercise? Well, 80 to 150 minutes per week. So that's 30 minutes, 3 to 5 times a day. The recommendation is about 80% of that be aerobic, 20% of that be resistance, exercises, like weightlifting. I would include in there flexibility. I do think some flexibility work is very helpful, especially as you get older, and it can help reduce pain. And you can do flexibility work, whether it's a specific set of stretches you like to do, whether you join a yoga class, Tai Chi. There's many ways to gently work on flexibility. Sometimes pool exercises can be very helpful. It doesn't really matter in my mind. What matters is that it's an exercise that you will do. The exact formula doesn't matter. And by the way, in terms of these exercise recommendations, the specific recommendation is for what's called moderately strenuous exercise, which is sort of the equivalent of a brisk walk. I don't know how many people can do 150 minutes a week of sort of that brisk walk pace. Keep in mind that almost any movement and exercise is going to have a benefit. If you do 150 minutes a week of moderate exercise, yay, that's fantastic. But even if you do 10 minutes of walking up and down your driveway, or a brief stretch class, anything that you do in terms of physical exercise is going to benefit you. And not to be too much on the soapbox on exercise, but it's the one thing that has been shown to reduce cancer risk, reduce obesity, improve longevity, reduce pain. If we had a drug that did as much for our bodies as exercise does, that drug would make a lot of money. It came out yesterday actually, there was a study that's in the British Journal of Sports Medicine. And this study predicts your chances of mortality in the next 7 years. That was the length of the study. And it's a simple test that they're advocating that doctors start to do in their office, which is you ask the patient to stand on one leg for 10 seconds. And you take the other leg, the stork's got it slightly bent in front of it, but you would actually put that one slightly behind you or on the standing leg. And the test has shown that if you can stand on one leg, either leg, for 10 seconds, you've got a pretty good chance that you're gonna do okay. But if you cannot do that after 3 tries, their study showed that you have an 84% higher chance of dying compared to your peers. Now, that doesn't mean you have an 84% chance of dying. It means 84% chance compared to your peers. So they cross-matched for, severity and age and all these kinds of things. But that's a significant amount. And, that's why they're suggesting this one-legged test. And while it does on one hand measure balance, and neuropathy could affect your balance, it does measure strength. In order to stand on your leg, on one leg, you have to have strength in your gluteus medius, your gluteus maximus, the muscles in your pelvis, around your pelvis. So it's a very interesting finding. And I suspect you're going to be asked more often to stand on one leg. But in my mind, it stands in as a proxy for exercising. People who exercise regularly generally do better on tests like this, in my experience. Okay, so we've talked exercise and I've been on my soapbox, and now let's talk anti-inflammatory diets. One of the things as a physician people would come to me all the time for was pain. And many times people have sort of body inflammation that leads to a lot of pain. It might be neck pain, back pain, muscle pain, but this body inflammation, there is a correlation to what you eat. And this is now, if you haven't gotten on the diet bandwagon, there really is good evidence that this makes a difference for us. Sugar is inflammatory. Processed meat, refined carbs, which can spike your blood sugar, for some people dairy, and for some people gluten, all can cause inflammation. You have to figure out what's right for you, but if you are having inflammation and pain, consider cutting sugar out of your diet for 2 weeks. I mean, actually nothing with added sugar, and read labels, because if you buy pre-prepared food, much of it has sugar in it, which has turned me into, over the pandemic, I started doing more and more of my own cooking. I used to do a lot of convenience food, but when I started reading labels more closely, it was shocking to see how much added sugar there is in many, many prepared foods. Because it tastes great, right? I like it. We all like it. And then, of course, increase fruits, vegetables, nuts, fish, olive oil. They all are considered and have been shown to be anti-inflammatory, especially things with either green leafy or red and bluish purple fruits like blueberries. Don't forget sun in the outdoors. It really matters. The Japanese have long had a practice called forest bathing, where it's a type of meditation, essentially. You go out and you absorb the forest. But it's been studied, and spending time in nature lowers blood pressure, improves sleep, improves mood, and then you get to make vitamin D, which has a host of other very good effects. And by the way, all of those things, the first three at least, not the vitamin D, all come from exercise. There's been a number of studies that show that exercise can be a pretty powerful antidepressant. So get your questions ready. I'm almost done. So I think this is the last slide before just a slide with my contact information on it. So if anything that I've said today makes you want to do something different, perhaps look at the number of medicines you're taking, talk to your doctor. Many doctors are really very receptive to this conversation, and the doctor to talk to would generally be your primary care doctor, your internist or family practitioner. In my experience, when a patient says, look, I want to see if I need all these meds, can we go through this, or even comes in with suggestions, they're usually relieved and quite happy to have that conversation. I do suggest that you also get ideas from other people. Social connectivity helps. For some people, they exercise better in groups. For other people, they're just looking for solutions. And so talk to your friends about what they're doing, what ideas they've come up with, or search online, Google some of these ideas and see what resonates for you. And, if you or your loved one's in a complex situation, consider hiring an advocate. An advocate will review your medical care, check on your medicines, improve your understanding of choices. And now I think that was my last slide, and I'm really looking forward to your questions. I really like doing questions. So I'm going to stop my slide share. What time is it? Oh, good. We're at quarter of, perfect. I'm going to stop my slide share. If I
You can just actually put this up so they'll have your information if you don't mind.
Okay. What would you like me to do, Laurel? Do I leave this up?
Keep that up, and then if you'd like, I can start asking you some of the questions.
Okay. Is there a way I can see you? Because I kind of like to see.
Can you see me? I have my camera on.
All right, then it's my setting. All right, I don't see you because it's, so leave this up. Okay, I don't know. I can't see you. I don't want to waste people's time, so I'll just wing it. So go ahead, Laurel, why don't you ask me the questions?
Alrighty, so we have one person who asked, why aren't doctors using PGX tests for Alzheimer's patients, especially when they can't communicate verbally? PGX tests of, studying how genes may affect the body's response and interactions with medications. So perhaps if you have any insight on that.
So I can't speak to PGX tests specifically, but what I can speak to is there is more and more bio-specific testing coming, which I think is the idea of the questioner. In other words, how individuals metabolize medications. Fundamentally, there are genetic tests that are being applied, actually more, we're seeing it in behavioral medicine, to help predict which drugs are going to be most effective. And their genome specific tests looking, where they looked at the genome and they've said, okay, in this person's genome, they have basically they have certain genes for certain enzymes that will or won't metabolize certain meds, and that has then been correlated into that then allows us as physicians, psychiatrists, etc., to get away from just try this drug for a month, see what happens, try that drug, and instead make an educated guess. As far as I know, there is no test today that, and I could be wrong, that will tell you exactly what a person will or won't metabolize at this moment in time, as opposed to a genetic predisposition. But I'd have to look into it.
Yeah, that's helpful. Someone asked if there's any type of test that could perhaps measure inflammation in the body.
There are some proxy tests for inflammation. We used to do what's called a SED rate for sediment, SED for sedimentation. There's another one for C-reactive protein, which can also sometimes be called the CRAPS test, the C-reactive protein. But you know it when you have it. When a person is inflamed, they feel like they feel arthritic, everything hurts, they're prone to headaches, there's a they may have extra joint pain. There is a feeling that happens when people have body inflammation. I'm not a rheumatologist. There may be some specific other tests besides SED rates and CRP tests, but they're not, those tests are not super helpful clinically, because frankly, the advice is likely to be the same. Change your diet, exercise, sleep better, get out in nature.
All right, wonderful. And then someone asked a question, is there any way to quantify how many medications have salt or sugar in them, how we can find what's in medications, and then perhaps what to do if we see that some medications have high levels of added salt or sugars?
I'm not aware of there being a problem with medications, the pills themselves having salt or sugar in them. There may be small amounts, but the dietary sources of salt or sugar are far, far, far more significant than I'm not aware. No, it's possible there's trace amounts or even something that I don't know. But I've never read of that being a concern from the pills themselves.
Awesome. So I know that answer to our question before was that about 5 pills is five medicines is a little bit too many. But someone asked, what if a person is taking 5 or more vitamins? Is that too many vitamins?
Well, so that's a question that's difficult to answer, because it depends on your medical condition and what you and your doctor say. There was just a study within the last month or so that came out that said that supplemental vitamins are pretty much worthless. Now, I got to tell you, I take a vitamin every week or two when I remember. I'm probably still going to take my vitamin. It just makes me feel better. So vitamins, though, are controversial. On the other hand, if you have a vitamin deficiency, and commonly vitamin B12 can become deficient, or vitamin D from not getting enough sun or wearing too much sunscreen, then you absolutely need supplements. But the role of supplemental vitamins in medicine, we've typically taken the, too many, take a multivitamin, it won't hurt you, might help you. But I will share with you, I had a client who I looked at his medication list. Unbeknownst to him, he was taking 3 different sets of vitamin D. He was taking it as a pill, and then it was in 2 other drugs that he was taking, combination drugs. So when it comes to vitamins, too much can be a bad thing. And so you need to read labels and not overdo it when it comes to supplements. And there isn't a count answer. It's a what's in the supplements you're taking, and are they water soluble supplements? Like vitamin C is water soluble. You could take tons of vitamin C and you're just going to get rid of it. Others are not water soluble, and it'll store in your fat, and you could actually have too much.
Yeah, I've seen that, like especially for vitamin D. You can take a vitamin D supplement, but then other vitamins have added vitamin D as well. So you could be just getting a lot of one thing. So that's very helpful. And someone was also wondering, you a lot that we were talking about today was for prescriptions. What about the effects of over-the-counter medications?
That's sort of what we're talking. I mean, an over-the-counter medication, whether it's a supplement or a sleeping pill like Tylenol PM, this is one where it's easy for me to say read the label, but read the label and check and see what that drug is that's in that over-the-counter medicine. I personally, but this is just a style, I tend to avoid the things like Tylenol PM, and if I want Tylenol and Benadryl, then I take Tylenol and Benadryl. Because I want to, for me, I'm just telling you what I do for me, I want to be able to control exactly the dosing of what I'm taking. I don't want something, you know, the such and such cold formula that comes with 3 or 4 medicines in it, because I just don't want all that stuff in my body. I want to treat the symptom that I want to treat. But it does take doing a little bit of footwork or talking to somebody who's familiar with all these different meds to be able to say, oh, okay, I'm going to take Mucinex because I've got this symptom, and I'm going to take a little bit of a decongestant for this symptom, but I'm not going to take the antihistamine. And a lot of these drugs, over-the-counter things, especially the cold medicines, just, you know, it's the kitchen sink. Again, it's not the end of the world if you do it, but every time you're taking a formulation like that, you're going to increase your chances, if you're taking other drugs, of side effects and adverse drug effects.
Yeah, so someone asked what I think is a really great question. How do we distinguish between fatigue from progressing dementia symptoms or side effects from antidepressant medications? How do we know when to increase or decrease the dose of drugs, since there can be many side effects?
That's a great question, and it all depends on the timing. So in other words, sometimes you have to stop a drug and see what happens to know if it's related to the drug. And some, you know, which I tend to go in the direction of less is better, less is more, but not everybody does. So sometimes there is no way. I had someone that I knew once who would say that every drug in the world caused side effects. You know, if her left foot itched, it was because the drug caused it. You know, in other words, sometimes things happen at the same time and they're not related. So you can have true, and unrelated. And the only way to know is to withdraw the thing that you think might be causing it and see if there's any change. And, you know, depending on the age of the person and the half-life of the drug, you may need a little bit of a washout period for the drug, a week or two, to see is there any change. And then add back in and see what happens, and then go up on the dose and see what happens. But that's what we as doctors have to do. There isn't a magic way to do it, because so many symptoms can overlap. And especially in dementia, it can be really hard to know.
Or it could be not dementia or the drug, or it could be something completely different as well that is coming on or trying to, you know, uncover as well. So it could be both, or it could be neither. So I think that's a really excellent point.
Well, and the thing that makes it so, sorry before you ask the next question, but the thing that makes it so hard, and I'm telling your audience what they know, is that when a person has dementia, you as the caregiver, all you can do is watch. You can observe, but you know, you might see a behavior that changes. Somebody becomes agitated or more quiet, but they can't tell you in the same way that you could express what they're experiencing. And so it makes it harder for the caregivers. It's tough.
Absolutely. Yeah, that's another very good point. We are starting to run out of time. So quickly, one other question is, if someone is concerned about their parent or another loved one, they're concerned about the medications that they take, what is a way that they could, you know, get in touch with their doctor or pharmacist to express the concerns about the medications that they're taking?
So that's a great question. So 10 years ago, I would have said, well, immediately pick up the phone and call your loved one's doctor. The thing that you want to make sure of, and just in case people aren't aware, your loved one, your doctor has to have permission from your loved one to talk to you. Excuse me. Feel like there's something there. They have to have permission as long as they're competent. So now if you were just to call your loved one's doctor, they may or may not talk to you. So you always want to be on the HIPAA list. You always want to have the doctor have written permission from your loved one that they can talk about you, talk about your loved one with you. So as long as that's in place, absolutely. And if you can, ideally, don't just call, but if you want to get the doctor's attention, go to the appointment. You don't have to go in person these days. You can go, I attend appointments where I appear by phone on a regular basis. You can do a video call or even set up a 3-way video appointment, but be present, because keep in mind that doctors are paid for person-to-person office interactions. So any phone calls they make, they're doing from their point of view for free out of the goodness of their heart. Now, one could absolutely argue that that's part of the fee and it's a reasonable point of view, but in reality, if you're there and you're in an office slot where they're being paid, you're gonna get better attention. So make an appointment and ask your questions with your loved one present, even if you come in by phone or video.
Yeah, I think that's an excellent point. I think that's really, a good way to kind of summarize at least year 2 special edition care connections, really being an advocate for yourself, for your loved one, finding an advocate, because this is tough. A lot of this stuff, this is not easy. So it's very helpful to have another person there to rely on, your doctors, ask your pharmacists, and, have this system in place to help you through these difficult moments. We're getting just so many questions. I am very sorry that we cannot address them all, but you do have Gerda's information here. So I do just want to, take the opportunity to thank you all so much for coming today, for being so interested and asking, such really great questions. And to you, Gerda, thank you so much for not just one spectacular webinar, but 2. So we were very lucky to have you join us. So I look forward to a next one, hopefully.
Yeah, to the audience, listen, reach out to me. If I can help you, I'm more than happy to do that. So afterwards, you've got my email address there. Happy to answer questions as best I can, keeping in mind that, I can't give you personal, individualized medical advice because I'm not your doctor, but if there's some general information that I can give you, I'm delighted to do that.
Yeah, absolutely. Well, thank you so much. Thank you everyone for coming. And I want to encourage you all to sign up for our next Care Connection. It is going to be on July 14th at 1 p.m. Eastern time. And we'll be joined by Anita Siddell. And she's the CEO and founder of one of AFA's member organizations called Toothbrushers and Balam Donkeys. Now, you heard me right. I did say donkey. So next month, we're talking about dementia, dental care, and donkeys. So if you're interested to see how all 3 of those come together into one, you got to sign up. And I look forward to seeing you then. But again, thank you, Gerda, so much. Thank you all so much for attending. And I look forward to seeing you all at the next webinar. But in the meantime, have a great rest of your day. Thank you all so much.
Bye now.
Bye, everyone.